Hi, Senator Scott Jensen, and I'm with Representative Mary Franson, and we're going to do today a little bit of a dangerous video. We thought about doing it as a press conference, but we're concerned that the information might get lost. So here we are. First off, COVID-19 disease is real. There's no question. In medicine, we know that the vulnerable are those people that are elderly with multiple underlying conditions. There's no question about, there's no argument about that. The hard part is to identify who the rest of the people are that are particularly susceptible to bad disease and potentially death. We're not able to identify who those people are. It can be a 45-year-old person, it can be a 63-year-old person. We know that somehow the immune system gets triggered in a way where it goes berserk, and whether we're dealing with a cytokine storm, mini blood clots in the lungs, whatever the disease process is, we know that COVID-19 can kill in a way that is exceedingly unusual. And when we talk about it in comparison to a severe influenza, this COVID-19 thing is unique in the way it does that. So having said that, I sort of got myself in hot water way back in April when I made the comment that I was, as a physician, being encouraged to do death certificates differently with COVID-19 than other disease entities. For 17 years, the CDC document that guides us as physicians to do death certificates has stood. But this year we were told through the Department of Health and the CDC that the rules were changing if COVID-19 was involved. If it was asthma or emphysema, follow the standard rules. But if COVID-19, then not. I have always held that my job in completing a death certificate is identifying the initiating event that began the train of events that led to a person's demise. But if it's COVID-19, we're told now, it doesn't matter if it was actually the diagnosis that caused death. If someone had it, they died of it. You don't die with it, said Deborah Birx, you die of it. In the same way, if it's a contributing condition, it's a part or a cause of death. Generally, a contributing condition, say diabetes, in maybe a person with heart disease, it would be a contributing condition. It would not be in that sequence of events. So once again, we're going to talk about death certificates. It's really important to note this. Death certificates have very little, if none, in terms of an impact regarding payment to physicians or hospitals. Physicians and hospitals will pay attention to diagnoses on the discharge summary from the emergency room or from the hospital. But when we're talking death certificates, we are not talking about payment reimbursement or incentivized. We are talking about death certificates and how that impacts our total deaths and how that impacts on our, if you will, policies that the governors around this country have put in place because they use the death certificate data to drive the program. Mary, you've been very concerned about the fear factor and how many deaths might drive the fear. Can you comment on that?
Sure. So when people live in fear, they make irrational decisions and they look at the world through different lens. Everything is based on, their life is based on fear instead of living their life to their full potential. And I see so many of not only just my constituents and not only those living in the state of Minnesota, but all across the world that are living in fear. It's COVID, 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 instead of the decisions that I want to make for my family, for myself. Instead, they're looking through the eyes of how will this affect COVID? Will I get COVID? Just by basically exercising their life, liberty, and their pursuit of happiness. And so, to your point, Senator Jensen, is that I was given the raw files from MDH on the death certificates, and it was a lot of data. And so I enlisted a team of some pretty smart people to go over that data, the raw files. So that my team took the files, reprocessed those raw death files. They recreated the daily death chart and then listed several examples of records where COVID is the underlying condition and where COVID is only mentioned.
That's a great point. Let me just unpack that a little bit. When you hear that 650,000 Americans died of heart disease, people might say, well, what if they had a heart attack, but they also had colon cancer? The key diagnosis on a death certificate is the UCOD, UCOD. It stands for underlying cause of death. If you actually look at a death certificate, you'll see that in Part 1, there'll be a line, the top line, that'll say immediate cause. Then there'll be below that perhaps an intermediate cause, and below that maybe another cause. But whatever the bottom line diagnosis is, that's the underlying cause of death. So if we just took a quick example and say that I have a heart attack tomorrow, and on Sunday I get an angiogram and they find that I need a stent, so they put a stent in because I've got some hardening of the arteries, and then next month we find that I had enough tissue damage that I developed congestive heart failure, and then the following month I developed pneumonia and died. Well, in a situation like that, the death certificate would say that my immediate cause of death was pneumonia, which was due to congestive heart failure, which was due to a heart attack, which was due to coronary artery disease. Now let's flip that situation around a little bit. Let's say it wasn't pneumonia. Let's say that it was COVID-19 pneumonia. Then the immediate cause of death would say COVID-19 pneumonia. And then that was due to congestive heart failure, due to heart attack, due to coronary artery disease. But the underlying cause of death would not have changed. So that death would be tabulated in the federal and state files as a cardiovascular disease or death. In the same way, if I am perfectly healthy and tomorrow I get COVID-19 and I die of it, that would be simply a one line on that death certificate. I don't have any underlying conditions. Nothing preceded it. Nothing else initiated it. I got COVID-19 and I died. So you'd have one line, immediate cause of death. That would be the same as the underlying cause of death. So the underlying cause of death is really important. And you did fantastic work in terms of identifying the underlying cause of death. We looked at 2,800 death certificate data points. But of those, what we found was that 2,000 of them had COVID-19 as the underlying cause of death, but 800 did not. That would mean that we've had the number inflated by 40%. But I think what you found was so interesting was for those COVID-19 deaths that have been tabulated in the Department of Health statistics, when it wasn't the underlying cause of death, what was the underlying cause of death that still might have been called a COVID death?
Sure, that's a great question. So I have some examples here, and I was shocked, Scott, to find this. Seriously shocked. So we have an auto accident. The passenger was ejected from the vehicle, but there was COVID in the system, so therefore it counted as a COVID death. I have other examples where COVID isn't the underlying cause of death, where we have a fall. Another example of we have a freshwater drowning. We have dementia. We have a stroke and multi-organ failure.
The CDC wants accuracy on the death certificates. And what Representative Franson has uncovered is not quibbling. We are not trying to be political. We are just trying to follow facts. These facts you got didn't come from some secret treasure trove. This came from the Department of Health.
Which that information is public data. Anybody can request that data.
In the Annals of Epidemiology recently, they came out with an article and they said some countries have attributed COVID-19 as a death with only confirmed cases, confirmed tests. Others haven't needed a test. Moreover, some countries have included COVID-19 when COVID-19 was assumed to be the death cause, but we were never told what the assumption was based on. So this isn't just a Minnesota problem or a U.S. problem. This is globally. I've had doctors from United Kingdom, European countries call and talk to me about that. Could you comment a little bit more about when you asked the Department of Health for the information and when you and some of your colleagues went through the data points, what were you feeling emotionally as you processed this and said, how can this be?
I think I'll take myself out of the lawmaking realm, and just as a private person, we get those emails every day that say how many people have died from COVID, how many deaths, and that right now we're at scary numbers that are being reported. But we're not told the full information. Was it with COVID? Was it from COVID? Which is, as I had stated before, leading people to live in fear, making irrational decisions that affect themselves, their family, and our state. Our state is shut down yet again. We have people that are unemployed. We have businesses that are being threatened, business owners that are being threatened to go to jail because we don't have the truth. That's what I want.
Well, you make a great point, and it's not just even stopping there. I'm just thinking of some of my patients I've seen where they've had a breast lump, and the last thing they want to do is go near a hospital or some place that could do a mammogram, so they waited. And I'm thinking of this one woman, she was diagnosed about a month ago with breast cancer, but she sat on it for 6 months. And the same thing with colonoscopies and all that. I know that I've been criticized, I don't know if you have, but people have said, well, you've implied that doctors and hospitals have an incentive to, if you will, massage the numbers. Well, you and I talked a little bit about how do the dollars from the CARES Act get put out there? I mean, the USA Today has already done fact-checking on me when I pointed out that the reimbursement to a hospital for a Medicare patient differs substantially if it's a standard garden variety pneumonia or if it's a pneumonia that's due to COVID-19. The substance of the reimbursement is significant. And the New York Times ripped into me for that, but then the USA came out and said, no, he's actually right. But could you comment on this second distribution where they didn't do it on past formulas, but they did it based on high impact distribution? And they went ahead and we saw some $22 billion distributed from the feds to hospitals based on what was the impact of COVID-19. What happened there?
Yeah, and this comes directly from HHS.gov. It's the CARES Act Provider Relief Fund. So all this information that we're going to talk about is public information. So HHS is allocating funding to hospitals that have a high number of confirmed COVID-19 positive inpatient admissions. There was $10 billion allotted to 395 high-impact hospitals. So there was a payment allocation per hospital, which equals the number of COVID-19 admissions, and then you times that by $76,975.
So for every patient that was discharged from the hospital with a COVID-19 diagnosis, that would count towards their hitting the threshold of 161, and they would get for every one of those, as long as they got to 160, $77,000 additional dollars on top of what they'd already been paid.
Yeah, the hospitals must have 100 or more COVID-19 admissions.
That was that second grouping. I know they did two distributions, and the first time you had to hit 161, then you had to hit 100. And I think on the one where you had to hit 100, they paid $50,000 per admission. And then I think the first one was $77,000. You're talking an average for many of these hospitals of $25 million. You're talking some serious dollars. Could you talk about what hospital systems in Minnesota might have been able to be in that 395?
Yeah, and once again, this is all on the website of hhs.gov. So we have Abbott Northwestern, and I'm not going to go over the dollar amounts, but Caris Health, District 1 Hospital, Hennepin County HCMC, Fairview, the Fairview chain there, Southdale, St. Joseph's, University of Minnesota. We've got the Maple Grove Hospital, Mayo Clinic, Methodist, Mercy, North Memorial, Regions, Sanford, Worthington, St. Cloud, St. Francis, and United Hospital.
Those are some pretty big healthcare centers. I didn't hear any smaller centers in that grouping, and so that does make you wonder, how are some of these in-between hospitals, how are some of these smaller hospitals going to survive? Because they're not being able to access these kinds of relatively significant dollars. I know I saw an article about HCA Healthcare. They had a huge second quarter. Some of these healthcare systems have been really doing well, but so many of them are just struggling on the vine. You know, part of what we're talking about here is exactly what Florida did when they called for an audit. And I really think that we need to, just as you have said, Mary, we need to have an audit in Minnesota. Somehow we need to have some master's or PhD candidates be hired by the Department of Health and come in and literally audit the death certificates so that we know what we're dealing with. Because if we have a 40% of our a 40% inflation rate of what's really our death tabulation for COVID-19 in terms of an underlying cause of death. if we have 40%, and that was at 2,800 charts, does that number, is that going to hold as we get out to the present 4,500 deaths, things like that? Again, the Washington Post, the Tampa Bay Times have recently ridiculed me because they've said that I've indicated that there's potential perverse incentives having been created in some of our policy decisions. And I was torn into because they said, yeah, this Jensen said that hospitals might make more money if they coded it a certain way. Well, it is the truth, because you can diagnose COVID-19 without a positive test.
Without a test, yes.
You can diagnose it simply on the symptoms and if there's transmission in the community. And I've talked to hospital administrators, and they've assured me that that is happening. You're not going to see hospital administrators jump up and volunteer that information and say, yeah, that's what we're doing. But you can certainly see that if you can get $77,000 per admission or $50,000 per admission, that is an incentive. These are hard times, Mary. I know I'm not going to be in the Senate next year, but you are going to be in the House, and all of Minnesota is going to be literally relying on your willingness to call out the hard facts. I can't tell you how much I appreciate what you do and what you're going to be doing in the next 6 months.
Well, finding the information isn't the hard part. What's hard right now is to see the people of Minnesota and all over the world suffer under COVID-19 with the lockdowns, the restrictions, their loss of their liberties, where I just want sunlight on the issue. I want people to have the truth so that they can make their own informed decisions on how they want to live with their life, instead of government saying, this is how we feel you need to live your life. And if you don't live your life the way government says so, well, we've got a jail cell for you. That's not living.
Mary, when we get on the other side of this COVID-19 thing, and we get the auditing done that needs to be done, and we look at whether or not we were comparing apples to apples or oranges to oranges, your legacy is going to be that of a truth teller. You're going to be one of these people who said, I know I'm going to take some heat. I know I'm going to be criticized. I am not trying to be political about this. I am simply trying to look at readily available public facts. And if you look at this, how can you deny the fact that some of these numbers are being massaged and it's squishy and murky? Thank you, Mary.
You're welcome. Thank you for your time.